Do I have the
Yeah, this is the May. This month of May is the awareness month. That's correct.
okay?
Schneider is starting the webinar now. She's starting live, but he will spotlight you on the hour. So you can click on start webinar.
Do I have the
Yeah, this is the May. This month of May is the awareness month. That's correct.
okay?
Schneider is starting the webinar now. She's starting live, but he will spotlight you on the hour. So you can click on start webinar.
Do I have the
Yeah, this is the May. This month of May is the awareness month. That's correct.
okay?
Schneider is starting.
So you say Professor John is coming in later, right?
I think so, Mandy.
Okay.
But you can start on the hour.
Right. Am I starting now?
Not yet.
Oh yeah.
Okay. It's time.
Hello, everyone. Welcome back to our Bloodless Medicine and Surgery Week. So, as you all know, May is the Bloodless Medicine and Surgery Awareness Month, and we are very honored that we can actually uh, have this wonderful webinar to raise the awareness about BMS as a superior form of healthcare, and is organized by BMSS in University of Calabar, Nigeria, in collaboration uh, with the Society of Advancement of Patient Blood Management, as well as the Malaysian Society of Patient Blood Management from Malaysia. And I would like to let you know, my name is Mandy, a hematologist from Malaysia. So today we're going to have exciting topics that will be spoken by our very prestigious speakers. So the first one I would like to introduce is Dr. Stephen Frank, who is actually a professor in Department of Anesthesiology and Critical Care Medicine in Johns Hopkins Medical Institutions, where he specialized in anesthesia for vascular, thoracic, and transplant cases. Dr. Frank is the medical director of Johns Hopkins Health System Blood Management Program, and he also directs the for the Bloodless Medicine and Surgery, a program for patients who wish to avoid transfusion. His recent work relates to the clinical studies in the area of collections and analysis of transfusion data from electronic medical records and methods for using such data to improve practice. And is currently on the editorial boards for the journals Transfusion and Anesthesia Analgesia. And he has served on the board of directors for AABB and SEBM. And he has also been chair of the Patient Blood Management Committee for the American Society of Anesthesiologists, and he has been chosen as a member of the Miller-Coulson Academy of Clinical Excellence, and he has earned the Distinguished Teaching Award from the medical students at Johns Hopkins. Dr. Frank is an outstanding member of the Bloodless Medicine and Surgery Society and received the Award of Excellence from the Society in 2021 for his excellent contribution to the science and practice of bloodless medicine and surgery. So let us welcome him to give a talk on minimizing blood loss, the second pillar of bloodless orthopedic surgery. Over to you, Dr. Stephen Frank.
Thank you so much, Mandy, for that very kind introduction. Let's see if this works. Can you hear me and see me okay? See the slides okay? I think
That's
so.
good. Good, Frank.
All right. So I'm privileged to be here this morning or afternoon if you're over in Nigeria. Our topic is minimizing blood loss, the second pillar of bloodless orthopedic surgery. And here we go. So there's no doubt that running a bloodless program is a team sport. And these are the members of our team at Johns Hopkins. We have a hematologist, Linda Resar, myself as an anesthesiologist, Isha Sherd is our clinical director, and then we have three patient coordinators, Liz, Andy, and Patrick. So for about the last 12 years, we've had a good team and a multidisciplinary effort to get patients through the hospital that don't want transfusions. So the question is, who can't be transfused? About 90% of our patients that we manage are there for religious reasons, primarily Jehovah's Witness patients. But the other 10% of our patients either have multiple alloantibodies from prior transfusions, or sometimes when there's no blood available that is cross-match compatible. So where do Jehovah's Witnesses get their belief that they should avoid transfusion? It was about in the 1940s when blood banks started to develop across the United States, and the Jehovah's Witnesses determined that they would not accept a transfusion based on these three passages in the Bible. And some religions believe they shouldn't eat the blood from other animals, like in kosher Jewish food and halal Muslim food. They take the blood out of the animal before it is slaughtered. However, the Jehovah's Witnesses take this to be a transfusion. So I think a lot of religions have this in common, only different interpretations. And I like to say that we used to think Jehovah's Witnesses were crazy until 1984, because if you look at the risk of hepatitis C in red and HIV in green, that was the absolute worst year to have a transfusion. That was the year I graduated from medical school, by the way, and patients were actually dying from AIDS or HIV that they developed after a transfusion. So it wasn't until 1985 when the HIV test came out, and then 1990 when the hepatitis C test came out. And you can see the blood wasn't really very safe all the way up until about the year 2000. So the Jehovah's Witness practitioners believe that nothing in the red zone is acceptable. So that includes whole blood, red cells, plasma, and platelets, but also white blood cells or leukocytes, which we rarely give anyway. And then the components that are in the green zone with the green arrows are considered to be a personal choice. So, for example, albumin or cryoprecipitate are a personal choice. Prothrombin complex concentrate, or Kcentra, we call it, is a personal choice. And in our experience, about 90% of our Jehovah's Witness patients will accept the products in the green zone, including hemoglobin-based oxygen carriers, which are not yet FDA approved, but there are two products that are trying to get approval, like Hemopure and Sanguinate. So we've had a program since 2012 at Johns Hopkins called the Center for Bloodless Medicine and Surgery. And back then, we opened our doors and started to care for patients who wanted to avoid transfusions. And the good news is that we run two programs side by side. We run a patient blood management program that aims to reduce unnecessary transfusions for the 99% of our patients that accept blood. And then we run a bloodless program for the 1% of patients, mostly Jehovah's Witnesses, who want to avoid blood completely. And the good news is that they have a whole lot in common. What's good for Jehovah's Witness patients is good for all patients. And we're going to go through some of those methods of blood conservation that we use in both of our programs. So, for example, treating pre-op anemia. That's good for everyone, Jehovah's Witnesses or not. And I'm a cyclist, and one of my heroes was Lance Armstrong, and his drug of choice was erythropoietin to build up his blood count. But it turns out that we use a lot more iron than we do erythropoietin because the most common cause of pre-op anemia is iron deficiency. If we have time, we'll use oral iron because it's so inexpensive. But about 10% of oral iron is absorbed. So we often are pressed for time and we go to intravenous iron. And these are the different IV irons that are available in the United States. You can see the one on the very left, the high molecular weight iron dextran, has been taken off the market because of a relatively high incidence of anaphylaxis. So we use primarily the low molecular weight iron dextran, which is also called InFed. And you can give a whole large dose of a whole gram or 1,000 milligrams in one setting to outpatients. So we often use iron dextran for outpatients and iron sucrose for inpatients. These are the two least expensive iron compounds. The ones to the right side of this slide can be very expensive, and there's very few reasons to use them. So we have an order set at Johns Hopkins that we put into Epic. We call it the blood refusal order set, or I call it the erythropoietic order set. And it gives the recommended doses of IV iron, erythropoietin, folate, and B12. It also gives the route of administration and the duration of the therapy. So we often, in the middle of the night, when our physicians call for help, we can direct them to this order set, and it saves a lot of time and effort. So when we treat pre-op anemia, the question is, what hemoglobin target are we aiming for if we want to avoid transfusion? So we created an algorithm to calculate the target preoperative hemoglobin that you need for an individual case to avoid transfusion. So we took the allowable blood loss formula that we all learn in anesthesia, and then we solved it algebraically for the preoperative hemoglobin level. And I'm going to show you how this works with a picture. So here's the algorithm put into action. So pretend that you are going to lose 1,000 mLs of blood on an expected surgery. That's the yellow line, okay? So you're going to lose 1 liter of blood. So if your patient is 100 kilos body mass on the x-axis, you need a pre-op hemoglobin of 9 on the yellow line. But if you're 50 kilos, a very small patient, you need a preoperative hemoglobin of 11. Because smaller patients have a smaller blood volume and a lower allowable blood loss. So therefore, they need a higher preoperative hemoglobin. So this algorithm is one that we use to calculate the pre-op target hemoglobin. So we were honored to be asked to write a review article on managing patients for whom transfusion is not an option. And I'm going to hit the highlights of this article that came out about 4 years ago. So we describe pre-op, intra-op, and post-operative methods that we use to avoid transfusion. And it turns out of the 16 different methods listed here, About 12 of them involve what I call keeping the blood in the patient. I'm going to show you what those are. And these are ways to reduce bleeding, because preventing severe anemia is a lot easier than treating severe anemia. Just like any other disease, we'd rather prevent it than have to treat it. So, for example, discontinuing anticoagulants before surgery, meticulous surgical technique. We'll talk about that in a minute. Less invasive surgical approaches like robotic surgeries can dramatically reduce bleeding. Keeping patients warm, normothermia can reduce bleeding. Cell salvage or the cell saver, we'll talk about that in a minute. ANH or acute normovolemic hemodilution, we use that a lot in cardiac surgery to use the patient's own blood in the operating room as a transfusion. And then controlled hypotension we use a lot for orthopedic and spine cases. Topical hemostatic agents like thrombin, gel foam, TisSeal, FlowSeal, those things really work. Tranexamic acid, I'll talk about that in a minute. Point of care testing, like the TEG or the ROTEM, decreasing blood draws and reducing phlebotomy blood loss. So I like to say that when surgeons try harder, they lose less blood. So blood loss is indirectly proportional to how hard the surgeons try. And I drew this curve myself. I noticed that when I bring Dr. Cameron here, a patient with pancreatic cancer, for a Whipple surgery, they usually lose about 1 liter of blood. But if I bring him a Jehovah's Witness, he'll lose about half that much, or maybe half a liter, because when they try harder, they tie off bleeders, cauterize everything, they lose less blood. In fact, notice that the most senior surgeons with the most experience are more willing to accept Jehovah's Witness patients, because when you've done, say, 2,000 Whipple surgeries, you feel more confident that you can do a case without a transfusion. So it's like a badge of honor, the surgeons, when they can take a patient and say, yeah, I can do this surgery without a transfusion. And then everybody, including the surgeons, feel good about their own skills. So what about temperature and hypothermia? So we've always known that patients bleed more with temperatures below 35 degrees centigrade, but there's even evidence that mild hypothermia, like 36 degrees centigrade, can increase blood loss by about 16%. So this is a meta-analysis showing that even mild hypothermia at 36 degrees can increase the relative risk of transfusion by 22%. I always thought 35 degrees was when patients start to bleed, but this suggests that even 36 degrees or very mild hypothermia can increase bleeding. So what about cell salvage or the cell saver? So this is what it looks like if you've never seen one. This is a machine that was invented about 1980, just right before the HIV crisis hit the blood supply. So everybody wanted cell saver blood back in the 1980s and even the 90s because we were afraid of transfusion because of viral risk. So the cell saver collects the blood you lose, it cleans it in a centrifuge by washing it, and then we give patients back their own red blood cells. And this has been called the centerpiece of blood conservation. Now, we even showed that cell saver blood is higher quality than banked blood. We measured 2,3-DPG in cell saver blood, shown in green, and found it was identical to fresh pre-op patient blood in dark blue. But stored blood or banked blood was about 90% depleted in 2,3-DPG, which causes a left shift in the hemoglobin oxygen curve. You can see stored red cells or banked blood is left shifted. So that makes it less able to unload oxygen at the tissue levels. But cell saver blood, on the other hand, was identical to fresh pre-op patient blood. So cell saver blood is higher quality than banked blood because it hasn't been stored for up to 6 weeks in the blood bank. And our small study was written up in the media about giving patients back their own blood during surgery. And I haven't yet met a patient who wouldn't rather have their own blood back compared to a transfusion with someone else's blood. Yeah, it got a lot of press. It must have been a slow news week. They said we recycle a lot of things, paper, plastic, and metal, but we can also recycle blood, give patients back their own. So what about phlebotomy blood loss? We took a survey in the 5 adult ICUs at Johns Hopkins about how much blood patients lose every day to phlebotomy. And it turns out 60 mLs a day on average is either sent to the lab or thrown in the trash as wasted discard. And 60 mLs a day, by the way, is just over 1% of your 5-liter blood volume, which is how much erythropoiesis you have every day. You destroy and create about 1% of your red blood cells. So you're basically canceling out erythropoiesis by sending that much blood to the lab. In the neurocritical care unit, they use this inline device called the Safe Set, and they managed to reduce the blood loss in half. And we've since switched to smaller phlebotomy tubes across the institution. We use the medium-size pediatric tubes almost everywhere. We rarely used the adult tubes that hold 5 to 10 mLs. And sometimes we use the neonatal tubes for Jehovah's Witness patients, for example, that only hold 0.5 mLs. So that's 5% of what the large adult tube can hold. We got to talk about tranexamic acid because it's being called a game changer now, especially in orthopedics. When we started giving tranexamic acid about 10 years ago to our total joint replacements, we saw this dramatic decrease in red cell utilization. We also hired 4 new surgeons at the same time, and a big trial came out in the New England Journal showing that less is more for transfusion. So this wasn't all tranexamic acid. When you look at all the TXA studies combined, you reduce bleeding and transfusion by about 30% if you average all the studies. Hemoglobin-based oxygen carriers. These go by different names like artificial blood or blood substitutes. But the 2 products that are trying to make it through FDA approval are called Hemopure and Sanguinate. These are bovine hemoglobin products that are cross-linked and polymerized, so they won't hurt the kidneys like free hemoglobin will. And these 2 products basically failed approval for the FDA back in 2008. And now they're trying to make a comeback, but we still don't have FDA approval. So these are given only under compassionate use, FDA emergency IND protocols when no other options are available. So we took the first 1,000 patients that we admitted for bloodless medicine and looked at their outcomes and cost compared to a matched group of controls. And this came out about 3 years ago. We looked at morbid events in the bloodless patients compared to a matched group of controls. And we found no difference in ischemic, respiratory, renal, or thrombotic events. However, we found a lower incidence of hospital-acquired infections in the bloodless group compared to controls. And this was statistically significant and also believable because banked blood is known to be an immunosuppressant that can predispose patients to hospital-acquired infections. So if we can avoid banked blood, we're less likely to have infections. We also looked at cost and charges, and we found about an 8 or 9% lower cost and charges for all the patients averaged together. This is median cost for bloodless patients was 8 to 9% lower than standard care because blood is expensive and infections are even more expensive. So it's a win-win to avoid transfusion. So we're supposed to focus on orthopedics for this conference. So I want to take you back to 2018 when we did an analysis of 4 years of orthopedic surgery patients before our patient blood management program in red and after our patient blood management program in blue. So you can see we reduced the hemoglobin trigger and target by about 1 gram when we started our patient blood management program. And the percent of patients transfused in the lower left was decreased by almost half. And then the mean number of units per patient transfused was reduced by about 1/3. And then when we looked at outcomes, length of stay was reduced by 33%. Percent of patients readmitted to the hospital at 30 days decreased by about 1/3. And then morbidity and mortality, morbidity decreased by half. Mortality was unchanged. So again, we can give less blood, tolerate lower hemoglobins, and have improvements in length of stay, readmission rates, and morbidity with no change in mortality. So even more recently, we looked at the return on investment for our comprehensive patient blood management program, and we found a 7.5-fold return on investment with equivalent or improved outcomes. And I'll show you how this works. So we took 10 years of data since we started our comprehensive patient blood management program. And on the left, we see a decrease in blood acquisition cost from $27 million a year down to $22 million a year in blood acquisition cost. But then platelets went up in cost with pathogen reduction. So the net decrease was about $3 million a year in blood acquisition cost. And then on the right side of the slide is the revenue that our hospital generates by taking care of Jehovah's Witness patients. We attract Jehovah's Witnesses from all over the country and even some from around the world that come to Johns Hopkins. And we recognize a $12 million net revenue per year and a $5 million variable net margin. So in other words, our patient blood management program either saves $3 million a year or generates $5 million a year. So that's $8 million benefit to the hospital every year. So I showed this picture of one of our recent patients with his permission. This is the day he left the hospital. He came in with a GI bleed, and his hemoglobin lowest level was 2.1. So he went to interventional radiology to try to embolize his bleed, but he still got extremely anemic. And we put him in the ICU and put him on comfort care, meaning the medical ICU docs were convinced that he would not survive without a transfusion. So we gave him high dose tranexamic acid, high dose erythropoietin, plus darbepoetin, along with iron sucrose, folate, and B12. And we minimized his phlebotomy blood loss. And the ICU docs were convinced he was not going to survive. However, I'll show you his hemoglobin trend, and he went home on day 17 with a hemoglobin of about 6. So here's his nadir hemoglobin of 2.1. We didn't draw labs during the dotted lines because we're trying to conserve his blood. But then you can see he left the ICU on day 7 and he left the hospital on day 17. And much to our surprise, he survived. So in 2012, when we opened our Bloodless program at Johns Hopkins, I never thought we would have so many publications. But now we have 2 more in press. So we have 15 publications over about 11 years, all on how to care for patients who wish to avoid transfusion. And this is Dr. John Cameron, who's done more Whipple surgeries than anyone else in the world. He ended his career at 3,000 Whipple surgeries at the age of 82. Pressure, patience, prayer, proline, plasma, and platelets. Except in Jehovah's Witnesses, we would avoid the plasma and platelets. And I want to end my talk by showing a 4-minute video, if you'll allow me to do that. So this is what we call Tammy's story. And Tammy was a patient who came from Roanoke, Virginia. And she came up to Johns Hopkins to have her ascending aorta and aortic valve replaced. She was turned down at 2 other hospitals because she wouldn't accept transfusion. And I'm going to show the 4-minute video. And I'll do my best to make it loud enough for you to hear. And here we go.
My neck looked like a bullfrog pumping. Have you ever seen like a bullfrog with a in its throat pumps like that? That's what my neck looked like. All that blood was regurgitating up there. These flowers are coming out pretty, aren't they? My name's Tammy, live in Christiansburg, Virginia. All my families, for the most part, has been really healthy.
Can you guys hear it?
I didn't know I had blood pressure problems.
Tammy presented to us with a large aortic aneurysm that you could see pulsating in the base of her neck, right above her breastbone. And that's a ballooning of the artery in the chest. Her blood pressure when she presented was 240/40. She had a leak in her aortic valve in her heart. So the one-way valve was allowing 2-way blood flow.
And yeah, I was like, this blood pressure is like, really? Why are you still alive? People couldn't believe you're still alive with this blood pressure like that. We searched for a place to go for 6 months. We found out that Andy Pippa was the coordinator for the Bloodless surgery program there at Johns Hopkins.
Tammy called us because she couldn't find a doctor or a hospital that would operate on her without resorting to a blood transfusion.
I did not want to do this no blood transfusion period. That's one reason it bothered me, because they said it was such a bloody surgery. But with my religion being a Jehovah's Witness, I wasn't going to take any blood. But I also didn't want to die on the operating table either.
The fact that she took her stand for no blood transfusion and the courage that she showed was an inspiration to me.
Our Bloodless program is designed to care for patients who wish to get therapy for their illnesses or to undergo a surgery without receiving transfused blood products. And so our role as the Bloodless program is to care for these patients, to get them ready for surgery when they need surgery, to keep their blood at a healthy level.
Every time we avoid a transfusion, we avoid potential complications like hepatitis, there's HIV, TACO and TRALI, which are complications from blood transfusion that can be fatal. Okay, so this is a fresh blood sample. So by avoiding unnecessary transfusions, we're actually saving lives. And I haven't met a patient yet that wouldn't rather have their own blood back as opposed to someone else's blood coming from the blood bank.
Nobody plans to go to the hospital. It's really a scary place to be. The fact that I can make a patient feel more at ease is key to their having a good outcome.
We had to be very careful with Tammy because we wanted to be sure that her level of blood, the strength of her blood, was at a safe level for her to get through the surgery.
We did several things special in the operating room. First, we did something called ANH, where we bank the patient's own blood right before the surgery begins. Then we used a medication called Amicar that reduces bleeding during surgery. And third, we use a device called a cell saver, which collects the blood that patients lose during surgery, cleans it, processes it, and then we can give them back their own blood before the end of the procedure. In Tammy's case, without the cell saver, I'm not sure we could have brought her through the surgery successfully.
As our Bloodless program has grown over the years, we've gained a lot of experience and expertise in caring for these patients.
By providing care to Jehovah's Witness patients, for example, we're perfecting methods of blood conservation that will benefit all patients.
The compassionate nature of this team, everybody on it, makes the patients feel special.
I'm very grateful for Johns Hopkins, for the Bloodless surgery team. I made it, and I did it without no blood.
All right, were you guys able to hear and see the video? Just confirming.
Yep.
Oh, good. Well, that's what I'm with you today.
What do you all the is the man he helps about beauty and show that I say no is of children for currently in more very this option let's try all the correct answer. So let us to the baseline bit.
So for like for me is the thing or I'm not in okay in you want to need from the meaning the any and where is left accident so I go this and then maybe how is this key or is just use play so get your beginning actually going or the real being percent so or to make that for the is here so I listen to that comes to be if she won't find it and she this series is said because she is not to set angel but to move to the to memory because it's good is fun to prove that she she was they put it we can really much so this is very no before we job it here good and me any the black and being the data to illustrate the results of the you even of the what my so sad because I really sad I use to this of because in the to do the this to make it good. Oh then so the and then the fish the transition to this of second was as about you being So as the regulation is in my all can she can be better. This is we have our own sale made us look and can speak so much on the can be very busy the is a point different the mobile was what it these are the problem there is to the district so clean up why any in the of the super incorporated in a outside or in possible testing. I don't know if immunity or so already I don't there is like but one bottle in ready to the on way. So the technique of is a by function and still is the of sending especially in our set and
years into the kingdom, yeah, and this and cure bay in the French, and what the
we had it had the all of the sea so do not do the member public in the display on is the basic for so the hypothetical break for rings and not important means make also before before to so is being major for me and things or is
we can bring information. We should share this with free of lots from our humans out of PCMs. You are believing for children who are the best of irons, fetch pretty and routine of lost out of the even or 7 years.
But I need to black screen and what we are so that you every only the same be defined sometimes in office.
I was curious, Steve, you gave a talk on orthopedic surgery. Do you have much experience with spines? And what have your challenges been?
Great talk, Dr. Hisam. I really enjoyed that. I am on the team that does the spines and the joints for orthopedic and neurosurgery, and they're claiming tranexamic acid is the biggest difference. That's what the surgeons are claiming. In fact, if they could choose between tranexamic acid and the cell saver, they think tranexamic acid makes the biggest difference. And controlled hypotension, they always ask us to aim for a MAP of 70 and then normothermia. And I think their techniques have improved because even the big open cases, not without the minimally invasive incisions, are losing less and less blood every time I look. So I think their technique is improving. And they also use a lot of topical hemostatics. And I should mention and question the group. We're told specifically not to let the topical hemostatics get into the cell saver reservoir because if they get into the reservoir, you can have a life-threatening DIC when you transfuse the cell saver blood. John, what do you know about that? Because I've never had a case where we had a problem, but we're very careful to avoid putting topical hemostatics into the cell saver.
Yeah, the microaggregate topical agents are small enough that they can get through microaggregate filters, which is the SQ40, the orange filter that we typically see. But there were some studies that were done in the mid 80s where they looked at the efficacy of the leukocyte depletion filters and found that they, with their use, would avoid any impact on platelet activation and aggregation. So I think in general, you can use cell salvage in that environment where you've got topical hemostats. But you have to do it, I think, with a great deal of caution, recognizing that if that stuff gets into the systemic circulation, you got a problem. So that's
Yeah.
my thoughts.
Yeah, the package insert says they should use a waste suction. to remove
Yeah, I mean, that's
remove
always a level of
yeah.
safety that you can, add to the use of it. But again, I think you can remove the stuff with leukocyte depletion filter.
Got it.
So, Mandy, did you have any thoughts?
Yeah, I just want to share. I can't switch off my WhatsApp.
Thanks, Mandy, for sharing.
Sorry, you're going to listen to my WhatsApp notifications. Right. So I think there's questions online from other people. Can I share with you guys?
Sure.
First, Dr. Frank, what do you think is so difficult to some hospitals or doctors to start a PBM program? And what do you think is the role of the nurse team?
Oh yeah, sure. Good question. So starting a program, I got advice from people who've done it before. For example, at the Mayo Clinic and at Stanford, and this was 14 years ago. And they said that what you need is a business plan and some monetary support. So if you're going to have a coordinator, like I know Jonathan has a coordinator, they need salary support. And even the physicians, if they're going to give lectures or make slides or write papers, they need salary support too from the hospital. So that's one reason why we published the paper on the return on investment. Because if you can show your hospital, hey, look, if you spend $1 on a patient blood management program, you can get $7 in return, okay? Then that's going to be a bargaining chip to get funding for your program. And I think that's the number one concern when you're starting a program.
So,
Right.
go
Sorry.
ahead.
Yeah, you can comment too.
I will. You first, though.
Yeah, what do you think? Starting a PBM program, I think is challenging.
It's very, very challenging. I got to say, I had a question for Steve. Looking at your slide, of acquisition costs, blood acquisition cost, it looks like you nadered in 2022, but the cost has gradually increased. And I'm wondering, first, what do you attribute that change? And secondly, do you fear, I mean, what happened to me in Pittsburgh is they cut my funding, the funding of my program is they felt that the program was mature, um, and which I don't think it was, but your trending is the same as what we saw in Pittsburgh.
Sure, yeah. Our blood spend did nadir about 3 years ago. And the reason it went up slightly since then is the cost of platelets. Because it was about 3 years ago when the FDA in the United States mandated extra measures to reduce bacterial sepsis from platelets, which, by the way, it was supposed to happen like 1 in 20,000 transfusions because platelets are stored at room temperature. So when the FDA mandated pathogen reduction for platelets, the cost of platelets went from $500 a dose to $650 a dose. So that's a 30% increase in the cost of platelets. And that's huge. So I used that dollar figure to try to encourage my colleagues to reduce avoidable platelet transfusions because no one knows about the increased cost. No one knows what anything costs in the hospital, at least in the United States. And so my job is to remind them that platelets just went up by 30% in cost. And that's an even better reason to avoid unnecessary platelets. And then John was saying about a mature program losing funding. So people think, okay, now that you're up and running, they think, oh, the Jehovah's Witnesses will come even if we don't have a coordinator. John, you could probably answer better than I can because we still have a coordinator. But I think the coordinators help a lot because two of our coordinators, no, actually three of our coordinators, 3 out of 4 are Jehovah's Witnesses themselves. And so when the patients come in, they feel right at home because they can speak the same language and they feel like they have a friend on the team. And so if we lost our coordinators, I'm not sure the witness patients would continue to come to our hospital.
Mind if, sorry to interrupt. Would you mind if I invite one of the very experienced people like Dr. Jamila Satta to share her experience on implementing
And that's the
PBM
Education Committee
as well
and my members.
as well as the
Thank you for
sorry.
sharing good lecture topics and discussion.
Sure.
Yeah, Dr. Jamila, what do you think?
Session and sent a smiley emoji and a folded hands emoji.
Yes, she's here. Thank you.
Hi.
I
I
think
mean,
she
like,
can
what?
share increasing the cost of the bloods, right?
Yeah, I think we're adding.
Is she online? Sorry, I just couldn't
My
switch off.
my internet line is not. I think it's a big challenge. I mean, we've been actually promoting patient blood management since 2012, and I mean, we have done a lot of awareness, yeah, but I think on the ground it's still not moving as fast as we hope to.
I think, did she freeze?
Yeah, I think internet connections.
Yeah.
I
Yeah,
don't, yeah,
yeah.
Dr. Waters, you go ahead. Thanks.
No, I think the administrators like Steve hinted at are really unaware of what the costs are associated with transfusion medicine. Um, we have tried to demonstrate, the outcome differences, and our administrators push back a lot, saying that we're doing multiple different things simultaneously, and the outcome improvements that we've seen in orthopedic surgery, for instance, are related to a combination of different things that have happened. It's not just the fact that we've reduced our blood
Sorry
use
about that.
40% to 0%. But Steve, I guess there's some other questions here related to the role of nurses in your PBM team. I mean, you hinted at the role of the administrator, but what about the nurses in your team?
Sure. I think nurses play a big role in dictating patient care. And the nursing care plans, which I didn't know much about until recently, we just developed a bloodless care plan for the nursing care plans, and we put that in Epic. And so I think that's going to make a difference. I'll let you know when we launch it because it's just being launched now. But things like sign on the door to use smaller phlebotomy tubes, and then reminding the providers that we might not need labs every single day, okay, when they keep coming back normal. Don't keep sending labs when they keep coming back normal every day. Things like that. And then we should think about treating the whole patient, not just their hemoglobin level, because some patients do fine with hemoglobins of 5 or 6, especially if they're chronically anemic. And so we shouldn't just use a a single number to worry about transfusion because chronic anemia is much better tolerated than acute anemia. And the nurses play a role in all those factors.
So I had a question for Dr. Hissam, and I apologize if I'm mispronouncing your name. The scoliosis patients that you take care of are probably universally children, are they not? Um, and have you faced any challenges with taking care of children? I know I've faced a number of obstacles with Jehovah's Witness children in my hospital where the pediatricians can get very ornery around not transfusing children at traditional levels. And so I was hoping that you might add some insight to that thought.
I think that the relationship with the pediatrician is always a special one. So I actually operate both adult and children scoliosis in two different hospitals. The pediatric hospital is managed by the pediatric medical. So at times the relationship can be very challenging, especially when you have to have a Jehovah's Witness. But okay, how I have our so far this combination of the autologous combination of cell saver plus the tranexamic acid with the anesthetist that is we will actually choose a specific anesthetist when we have a difficult case like this, and also this will actually help to have make the patient have zero blood transfusion during the surgery. Regarding the hemoglobin, is actually how I can make it. I want to say very politely because sometimes, as Dr. Frank has mentioned, a hemoglobin of 5 or even 7 that is internationally that the pediatrician want to transfuse already. But luckily in our place, the final say is always to the surgeon. As the head of the team, you always have the final say. So when the patient is 7, is doing well, the pediatrician want to transfuse, we will discuss with the parents the pro and cons of everything, and then the parents will make an informed decision which will override the pediatrician. So that's how we put it. We put the ball on the patient's, let the patient have the final say. So we as doctors, we do not have the final say because the body belongs to the patient. So we always make our patient have the final say.
Yeah, I think that's something that's oftentimes forgotten is that the patient has ultimate decision power over their own bodies. And I've dealt with some pediatricians that were fairly aggressive and telling children that they're going to die if they don't get a transfusion when they came off of the playground, an hour before, and all of a sudden they need a transfusion. It's kind of crazy. Um, but anyway, do you have a transexamic regimen that you use post-operatively, or is it all intraoperative that you use the topical and the intravenous tranexamic acid?
We don't use any post-op tranexamic. We only use intraoperatively local and IV. IV we give 1.5, local we use 300.
Okay. I see we have a question from Neil Blumberg. Neil is an esteemed colleague at the University of Rochester. So if we can open up the mic to, there he is. Okay. Hey, Neil.
Hey, John. Hey, everyone. I was just answering Nathaniel's question about why, and other people's question about why PBM programs are so hard to start. Um, our own experience was that, as some of you know, we've been interested as hematologists and transfusion medicine specialists, not orthopedic surgeons or anesthesiologists, in the side effects of transfusion that had not been previously appreciated for most of the years. And I think most of you are aware that this body of literature, which could be called transfusion immunomodulation, suggesting transfusions increase the risk of multi-organ failure, infection, thrombosis, just about all the bad stuff that can happen in particularly in surgical patients. There's been a lot of pushback, and I think hospital administrators don't like to spend money and on new programs where you're putting money up front in hope of benefit to patients and savings down the road. And Steve, in particular, Dr. Frank has made immense contributions to this literature because he's shown that, practically speaking, implementation makes an enormous difference in clinical outcomes. And it's one of those rare things in medicine where you improve clinical outcomes and save money. As a hematologist, usually you want to save somebody's life, you got to spend a lot of money on them. This is something where you spend money on upfront, but the downstream benefits are there. And so I think our administrators refused to start a PBM program despite my pleading for like a decade or two. And it was only when they went to meetings with other administrators who said, "Oh, we've got to hear about this great stuff they're doing at Hopkins and other places and saving money. Would you like to start a PBM program?" And so, about 10 years ago, we finally had a PBM program. So it's a complex thing. And I think it's a combination that your clinical people, you need to have champions somewhere in there, whether it's the cardiac surgeons, the orthopedic surgeons, the hematologists, or the anesthesiologist, somebody who's not, in a laboratory base like ourselves. Um, and if you can get that enthusiasm and people realizing, yes, we're doing harm with our standard practices. And this is a very hard, a difficult pill, I think, for clinicians at the bedside to accept that the things we've been doing are harming patients. And I think, Steve mentioned platelet transfusions. The one thing we've learned in the last 10 or 20 years is platelet transfusions in many patients, A, don't work, and B, they cause harm. Because we've got 3 randomized trials now showing that standard platelet transfusion practices increase bleeding and increase mortality. What impact has that use had on the use of platelets? Zero. Our platelet use, like many others, has continued to go up, and some of that is my colleagues in hematology who have a deep religious belief in the benefits of platelet transfusion, and many intensivists and surgeons feel the same way. So the whole story of how we have learned that transfusions are much more complex biologically and clinically really needs to be told over and over again. Not to, brand the blood bank as somehow the purveyor of evil. I'm a transfusion medicine service director, but that it's much more complex than we thought. Anyway, sorry to go on indefinitely. I really enjoyed that, in particular, these 2 talks because they were so focused on the patient and how we can do better for patients. And I think that's what this society is about.
Neil, in your comments, you highlighted platelets, and I'm wondering if you have any thoughts about the work that's being done with cold stored platelets and whether or not that would change your perspective on your thoughts, or is it just too soon to say?
I think it is soon to say, but I don't think it's going to make a difference. I think there are 2 things in the standard practice of platelet transfusion that we're not going to be able to overcome in any easy way. One of which is blood transfusion services do not believe that ABO matters for platelets. This is a total nonsense. There's extensive data that ABO matters. It matters for red cells. It matters for solid organ transplant. Why would we think platelets would be different? But your blood bank in most hospitals is going to give you whatever's about to outdate, whether it's ABO identical or not. And this is a catastrophe because it increases organ injury, bleeding. Basically gives you something equivalent to lupus or rheumatoid arthritis, where you have immune complexes circulating. So you're going to have increased bleeding, increased thrombosis. So that's one thing, which is on our blood bank people. It's best not to get into that too deeply here. But the second thing is that storing platelets are like white cells. They're very active metabolic cells. They deteriorate very quickly during storage, and they're pro-inflammatory and pro-thrombotic. And I think that's going to be true whether they're cold stored or not. I mean, cold stored red cells, which are metabolically much less active and not involved as actively in the immune system or inflammation. Cold stored red cells or allogeneic red cells are not very safe, even when you leukoreduce them. We have found that minimal manipulations like leukoreduction, autologous transfusion, restrictive transfusion, and something that's incredibly unpopular in blood transfusion circles, washing to remove all the glop that accumulates in the supernatant, the membrane fragments, the free hemoglobin, cytokines in the case of platelets. That actually has clinical benefits, but I think the problem is that we were so successful with transfusion in the early days and stopping people from dying who were exsanguinating that it became through indication creep so popular to use transfusion to correct numbers. And this has been a catastrophe for patients. I know that's not a popular point of view, but
Well, I think
I've
there's
answered your question, but cold stored platelets are not going to be the answer to anything with the
tell
current
that
practices because
let
it
the
doesn't, the
filter
stuff
vanilla.
doesn't work. The stuff doesn't work to begin with the way we use it in the blood bank, whether it's cold or warm or look at it cross-eyed. And the way the blood bank handles it causes all sorts of problems. So I think it may be slightly less toxic in some situations. I wouldn't be surprised, but I think we still have problems.
Yeah, I agree. If you look at a platelet cross-eyed, it does start aggregating and degranulating, and so there's lots of things that happen with platelets that I don't think are well described. But anyway, I think we're getting close to our end time here. Um, does anybody else have any thoughts regarding this discussion, or should we move on? Mandy, do you have anything to add?
Well, I think it's really wonderful comments from Professor Neil Bloomberg. And I would like to actually ask maybe Professor Sharaf, is he online? Whether he wants to comment one or two about bloodless surgery in scoliosis. Professor Sharaf, is he there? Oh, no. I think that's all right. I think
Yeah,
Professor.
sorry, Mandy. Yes, I'm here. I'm here. I've enjoyed all the talk and the discussion. And I think it's good that you had a lot of questions from the audience. So I just like to thank everyone for their wonderful talk. I think like like Dr. Jamila, who's my wife, mentioned, the PBM is really a long journey. We've been doing it for the past 13 years, and it's a struggle. But I think we're getting our converts gradually. So we carry on, and hopefully we get more and more people on board to implement PBM. Thank you.
Thanks.
Thank you, Mandy.
Yep.
Before we close, there's one more question here for Steve, I think, regarding PCCs, prothrombin complex concentrates. There's an individual from Ghana who apparently is having trouble with acquiring the PCCs. He wants some contacts to help him procure some. I'm not sure you can possibly help him, but any thoughts about the PCC use?
Sure.
Thank you.
Yeah, I know in the only FDA approved indication for prothrombin complex concentrate is urgent or emergent reversal of vitamin K antagonists. That being said, a lot of places are using it off-label. The problem is in the United States, the typical dose is about $3,000, and the equivalent dose of plasma is about 1/10 of that or less, maybe 1/20th. So we're stuck in a system in the United States where we pay more than all other countries in the world for expensive products like prothrombin complex concentrate. And I know there was just a study that came out 2 weeks ago, a randomized trial in cardiac surgery, out of was Kevan Karakudi and Jeannie Callum in Toronto, showing superiority of PCCs for bleeding cardiac surgery patients compared to plasma, with less bleeding, less coagulopathy. And it was one of the few studies where they didn't show non-inferiority, but they showed superiority. So that just came out 2 weeks ago, like the last week of April. So we'll see if that has an impact or not.
Right. I think with regards to the PCC, Dr. Jamila, are you online? Hi, Dr. Jamila.
Looks like she's online, just muted.
Dr. Jamila, because I think she has a lot of experience with this. Because I think we have to be careful with this prothrombin complex concentrates. Usually you're talking about a warfarin reversal. It's the 4-factor, the one with the factor 7 inside. And some of them is with 3 factors. That one is actually not really much help. And I would say that you have to be careful in the sense because it can associate with increased thrombosis again with patients because it has a lot of other factors that may not be needed. Right, Dr. Jamila, are you there?
Yes, yes, yes.
Yes.
Yeah, I just worry that I mean that there is a trend now, for surgeons and anesthetists to use PCC off-label, in managing severe hemorrhage. So yeah, it's just because now the only indication for PCC I would say is reversal of warfarin, over warfarinization, reversal of warfarin. But it's worrying that we're seeing off-label use of PCC. Yeah. Just like Novo 7 too, right? We're using it off-label, and always the risk of, thrombosis.
So I put the new randomized trial in the chat, and what they showed is superior hemostatic efficacy with safety advantages over plasma. It's an unblinded randomized trial in cardiac surgery, and I'll let you guys be the judge. Over 500 patients.
How about Professor Bloomberg? Does he have? Is Professor Bloomberg there?
Well, yeah, this is mirrored, of course, in the original licensure trials in Europe and the United States for vitamin K antagonist reversal. Mortality is halved by using prothrombin complex as opposed to plasma. So this is not a huge surprise in some ways. Plasma, which we tend to think of as, just a coagulation factor source, is also pro-inflammatory and prothrombotic, just like prothrombin complex. Maybe worse because there's lots of other stuff in plasma that isn't in prothrombin complex. But we've just begun to study that, I think.
Well, our time is kind of up. We have some videos that we're supposed to view, but I've been instructed by Nathaniel that Gary had some comments, and I don't know if we have the capacity to open up the discussion to Gary. Um, And if not, maybe Mandy.
You want me to carry on with the video?
Yeah, maybe we can do one video, and then if Gary wants to pipe in after the video, then we can answer his questions or hear his comments. So I think you were going to introduce the first video.
Yep. So we're going to show you the first video, which is related to bloodless medicine and surgery. What you need to know. It's about 4 minutes and 41 seconds. Over to you, Snyder.
Providing bloodless care to patients is simply providing medical care without giving patients blood donated by another person. The way we do this is to conserve blood by reducing or eliminating bleeding, by stimulating the body to make its own blood cells at an accelerated rate, and also by recycling blood that patients lose during surgery and giving them back their own blood. Well, there are several reasons why patients may choose a bloodless approach to their surgery. Historically, patients have elected to avoid transfusion because of religious reasons, but also some patients just simply wish to avoid the risk or the side effects of transfusion. For example, we know that patients treated with the bloodless methods have a shorter length of stay, decreased incidence of hospital-acquired infections, and also less chance of an allergic reaction or even receiving the wrong unit of blood, which still occurs. The first thing we do is we diagnose or treat anemia prior to surgery, so patients come to the operating room with enough red blood cells so they can tolerate any blood loss. During surgery, we can avoid hypothermia or hypertension, both of which can increase bleeding. And then we can collect and recycle the blood they lose using the cell saver and give them back their own blood during surgery. We can also use what we call ANH, acute normal volemic hemodilution, which is where we bank the patient's own blood at the beginning of the case and give it back to them at the end of the case. There's one more technique. There's new versions of electrocautery that have come out recently that can dramatically decrease bleeding during orthopedic cases and during spine surgery, for example. Virtually 99% of all the procedures we do can be performed without transfusion. For example, we've done some really big surgeries like a Whipple for pancreatic cancer. We've done many of those without transfusions. We've done open heart surgeries, even revision open heart surgeries for valve replacements and bypass surgery without blood. And recently, we even did a 6-kilogram baby, that's about a 14-pound baby, who had open heart surgery for tetralogy of Fallot, requiring cardiopulmonary bypass without a transfusion. We believe that we offer more different types of specialty care than any other hospital in the country that has a bloodless program. Plus, our program blends seamlessly into the care plan that's offered by all varieties of specialties within the hospital. Surgery itself is becoming less and less invasive. For example, the laparoscopic and robotic approach to different surgeries have dramatically decreased the amount of blood that patients lose and the amount of transfusions they require. Also, we're giving new intravenous medications like iron, or we're even giving erythropoietin, which is one of the medications that the professional cyclists use to blood dope. Only now we're giving it legally to our patients to build their blood counts prior to surgery so they don't require a transfusion.
Well, Steve, you looked much younger in that video.
I had no idea you were going to show that. I forgot it was even made. That might have been 10 years ago.
That's my comment. Um, I don't know. It's pretty much a follow-up on our entire discussion here.
Is there a second video? No,
Was that?
Dr. Waters, is there any second video?
There apparently is supposed to be one. I'm not sure if this is. We have another video from Steve and Johns Hopkins. I'm not sure. I wasn't given a lineup of the videos, but there are apparently another one that.
I also don't know what is the video about, but I know that in the email is written.
Yeah, yeah.
Okay, maybe we can save that one for later.
Yeah, I was particularly interested in one at.
Oh no, Snyder is showing.
Okay, Schneider is gonna do it.
Every year in the U.S., patients receive 21 million blood transfusions. What if there was a better solution with significantly improved outcomes?
So nearly every surgical procedure involves some degree of blood loss. And traditionally, we give patients blood from the blood bank. However, another option exists, which is called bloodless medicine and surgery, where we use alternatives to transfusion.
Techniques performed before, during, and after surgery result in minimized blood loss, faster recovery, fewer infections, and quicker discharge. Bloodless medicine eliminates the need for blood transfusion, thus avoiding the dangers of allergic reaction, contamination, and the possibility of receiving the wrong blood type. Before surgery, medication and nutritional supplements increase hemoglobin levels, which help your body handle blood loss during surgery. A process called hemodilution temporarily replaces a portion of the patient's blood with fluids, lessening the impact of blood loss during surgery. Tools and techniques used during surgery include anesthesia processes to safely lower blood pressure. Harmonic scalpels clot the blood while cutting the tissue. Cell salvage machines collect lost blood, wash it, and return it to the patient. Hemoglobin monitors reduce the need to collect blood samples to be sent to the lab. After surgery, medications and techniques can minimize bleeding and improve oxygen in the blood. Often after surgery, blood must be drawn to run follow-up testing in the lab. Microsampling requires 1/10 the amount of blood traditionally drawn, reducing the amount of blood patients lose by almost 90%. At Johns Hopkins, our team of highly trained experts have been providing patients alternatives and peace of mind for years.
Well, I can see my problem is I've not made enough marketing videos.
It wasn't my idea. They told me we had to do it.
Well, I think it's another kudo to Steve and his program, what they've done and built, and the marketing that Steve has done, as we've just seen, plus the voluminous publications that he has presented for us are really pretty remarkable. So, anyway, do we have anything else that we're supposed to, maybe if Gary is out there, is there a way of opening up the mics to everybody so that they have their opportunity to talk or ask questions? I'm not sure if Schneider is the one that does that for us.
There's still a question there for Dr. Hisam, if he's around it, to answer it.
Are you talking about the tranexamic acid, carbazochrome, and vitamin K injections prior to the surgery?
Yes, yes,
Uh,
but was it answered already?
yes, is Dr. Hisam there? Hi, Dr. Hisam. Prof?
Yes.
Yes. They're asking you tranexamic acid, carbazochrome injections, and vitamin K injection. Do you use it prior to surgery? It's a cocktail.
No. Being in the university, majority of our practice is has been I don't really do all this kind of thing. I have to have evidence before I decide on it. So I don't use but this cocktail. Even to have the tranexamic acid, we have to make a study to prove it work, then only we can use it. We have to make a study to show that the cell saver work, then only we can use it. So and to get the approval for ethics is very difficult. So sorry, I don't use it.
Yeah, I mean, carbazochrome is not approved by the FDA in the United States, so we don't really have access to it. I don't know, Steve, have you used it experimentally at all?
I don't even know what it is. Can you say it again?
I'm not sure I'm pronouncing it right. Carbazochrome?
Sorry, I also first time hearing it.
Yeah. I mean, I just did a quick Google search. It works by promoting platelet aggregation and adhesion, which forms a platelet plug to stop blood flow from open wounds. It's not FDA approved, but is available in some countries for treating hemorrhages and other bleeding conditions. So maybe if we could open up to commentary from the audience, we might learn something here about this particular drug. If you have a comment, raise your hand.
I do. I'm sorry, I didn't raise my hand. Let me raise my hand. So I do use, I use two of those. That is tranexamic acid combination with vitamin K, and it's very effective.
What about the third drug?
Carbazochrome.
Just like Steve, I've never heard of it.
Okay,
So
but
I'm
you're the
not
one
alone.
that you put the comment into the chat, so
I was just copying from I think it's Ikini or Igin.
okay. Well, it's something to tickle our interest with, I guess.
John, you and I mean, most of us know about desmopressin or DDAVP.
Yeah.
So if I'm doing a big trauma case or a big transplant case and I've got over 50,000 platelets, but the TEG is still abnormal, then we'll often give desmopressin or DDAVP to help the platelets work better. And so I'm not familiar with the other drug you mentioned, but I bet most of us have used desmopressin in that way.
Yeah, I used to use desmopressin, but a lot more in a former era where we had hetastarches as a volume expander, because the hetastarches would bind factor 8C, and you could reverse that effect with the desmopressin. I haven't used it in quite some time since we've kind of eliminated hetastarch from our
I have used it
expander. Yeah.
in Hildebrand disease as well as my hemophilia A.
John, you probably work in one of the busiest labor and delivery departments in the country, if not the world.
Not
What's
really,
your
I'm just working in a hemophilia
I know you do like 5 times more deliveries in Pittsburgh than we do at Johns Hopkins. So what's your secret to stopping a postpartum hemorrhage?
A hysterectomy. uh,
So
that's all.
that's not even funny because some obstetricians can get a uterus out very quickly and some can't.
Yeah.
And so you're exactly right. That's the definitive treatment, but not everybody can do that quickly without bleeding.
Well, I've become a big fan of interventional radiology and being able to embolize bleeding uteruses. Um, we had a 16-year-old that had a postpartum hemorrhage at McGee a number of years ago, and she ended up losing her uterus, and the family was quite upset because she no longer had fertility. And she only had one baby, who I think that particular baby ended up expiring or passing. Um, so we've become increasingly reliant on interventional radiology to stop the bleeding, and almost universally it works and quite effectively. Um, and I know there's some institutions, I believe Brigham and Women's has built a interventional radiology suite within their labor unit, which we looked at briefly, but the cost was about $10 million, which is a big um, prohibiting factor. So we haven't done that, but that's the magic sauce in obstetrics is really the IR.
Mhm.
Um,
I think I have to, Nathaniel just posted another questions. From your experience for all the panelists, which topical hemostatic agents are quite effective in managing bleeding during surgery? If possible, could you comment about their availability in Africa and Asian countries with limited healthcare?
I know people talk about Flow Seal and Tisseal that are made by Baxter and quite expensive, but you can also make your own version of Flow Seal by combining thrombin and gel foam together, and it's a lot less expensive. The thrombin comes in a vial, the gel foam, we know about that, and you mix them together. And so we have some spine surgeons that use that instead of Flow Seal because you can save a lot of money by making your own product with less expensive ingredients.
Wow.
I think
How
the
about
most important thing you can do is maintain your own platelet count, and I think what Steve alluded to earlier with normovolemic hemodilution. I mean, with that particular technique, you save your platelets for the end when you want to control microvascular hemorrhage, and you need about a liter worth of whole blood to be um, captured at the beginning of the surgery to correct any platelet defect at the end. But it's an extremely effective technique, at least I've found, especially in spine surgery. Um, it can be pretty miraculous. And that can be done in African and Asian countries.
let's ask Professor Hisham. What do you think? He's a spine surgeon. You're muted, Dr. Hisham.
So currently it's Flosil, but before we have Flosil, it is what Prof. Frank mentioned earlier. So it is the thrombin plus gel foam. It works very well actually. So but nowadays the availability of the Flosil makes your job a little bit easier because your nurse can prepare it. So my current choice is Flosil.
Thank you, Dr. Hisham. Yeah, Dr. Waters.
Well, I was wondering from Nathaniel or others, um, there was a comment about Gary, several comments from Nathaniel. Do we have a way of getting Gary back on? And
Gary is a perfusionist. We actually brought him on, but he wasn't speaking. He had raised his hand and we unmuted him, but he wasn't speaking. So maybe he was busy trying to move blood from one chamber of the heart to the other.
Okay.
And I think right now it is not on.
So Nathaniel
But I think Schneider has one more video, I think. John,
Okay.
you were saying something?
No. I was wondering if there was more that you wanted covered, but another video would be great.
People feel that if you don't receive blood, you're getting alternative care and the care is not as good. That's the myth and that's the misconception. There are times that giving patients blood is more dangerous than not giving it to them. We have an armamentarium between the medical breakthroughs, the surgical techniques, and the anesthetic techniques that we use today enable us to treat patients in a safe environment without the use of blood transfusion. It's better medicine if one can be treated without the use of blood transfusions when you avoid all of those potential complications, both infectious and non-infectious. It is, so to speak, the gold standard, and hopefully it will become the standard of care.
Hi, Dr. Waters.
Well, we don't have, it's all banging the same drum. I mean, I think, we've all drunken the Kool-Aid, so to speak, and I think our patients, at least in my experience, do better if we don't transfuse them. Sometimes you're backed up against the wall, so to speak, where you have to transfuse, but in many circumstances, you can certainly get away and not have to transfuse patients. So I think it's hopefully, I mean, it's been 20 years since I've started in the bloodless medicine world, and I believe that we're starting to see an increasing interest in patient blood management, and hopefully it will continue. So that's pretty much all I have to say. Anybody else have anything that they want to comment on?
Actually, there's a lot of questions, but I think we just don't have the time.
Well, I think we have 4 more minutes if there are questions.
Oh no, somebody is asking, is there a need for early use of TPO mimetics before the platelet drop below 20? Yeah.
Thrombopoietin drugs. I know they exist. I know we've used them maybe once every 3 years, but they're really expensive. I think they work. And I also agree with Neil Bloomberg that patients tolerate a lot lower platelet counts than we often use to trigger platelet transfusions. I know in transplant, we use 40,000 platelets as a trigger routinely. In cardiac, they're using much higher levels of platelets, but I'm not an expert on the TPO drugs, to be honest.
Well, that's a drug that's used in hematology. We don't really use it in a surgical environment. And, I mean, that's the thing about patient blood management is most of it's been focused on surgical transfusion. There's very few people that have delved into the hematologic world. Pat Ford at Penn has done so, where she's doing I think bloodless stem cell transplants. But outside of that, there's very few individuals that have really gotten into that world.
I myself is a hematologist, so I
Yeah,
have
there
used
you
them
go. Yeah.
in idiopathic thrombocytopenic purpura mostly. But to me, you have to find out what's the reason of the platelet low. And then we actually can get away with steroids and even IVIG with all these patients, right? If both of you agree with me, you don't really resort to this TPO mimetics a lot of times. Right. I
Yeah.
think we Dr. Waters, what do you think?
No, I was going to say IVIG is the cure for everything. That's, but I think we are at the end of our time.
Yep.
So I'd like to thank everybody for spending their, I guess, the morning in Pittsburgh, but I would guess it's probably in the afternoon or evening for you guys. So thank you for your contributions to this forum, and I'm really happy and proud to be part of it. So thank you.
Yeah, I also would like to thank everyone. Thank for all these wonderful panelists and speakers and chair, and as well as all the people coming in to join us with such a wonderful discussion. Nathaniel, can I carry on to tell the program next tomorrow? Yeah. So
Yes, I've shared it.
yeah, so before we close, I would like to remind everyone, please stay tuned for tomorrow. We have our BMFS continue on, where Nathaniel is going to talk to you about why use 1 when 0 is best, recent evidence in favor of bloodless surgery. And the second speaker will be Howard Mazin. He'll be talking about use of intravenous iron in pediatrics populations. And the third speaker will be a keynote speaker, Craig Iberson, will be talking about bloodless pediatric orthopedic surgery. Please stay tuned, everyone, before we close the session. What do you think, Dr. Waters?
I think we can do it.
Yeah. And how about Nathaniel?
Oh, yeah. Thank you so very much.
Thank you. Have a nice day.
Yep. Thank you, everyone.
Thank
We
you.
see